all of you. A few housekeeping details before we get started. This program is being recorded so that it may be viewed by participants unable to join us tonight. All webinar participants will be muted throughout the program. We encourage you to submit questions through the chat room function if you're using Zoom. You can also submit questions by email at beaust@us2.org. That's beaust@ustoo.org. We expect more questions tonight than we can answer live. We will post selected questions and answers on both the TOO and the AnCan websites. With that, I'll turn things over to Rick Davis of AnCan. Thank you.
Can you hear me? Am I unmuted? Okay. So thank you, Bo. And I'm Rick Davis. I'm the founder of AnCan, and we are us2's virtual support group partner. We run 9 virtual prostate cancer groups with us2, and AnCan runs 24 groups altogether for 9 different conditions. And we are one of the innovators, if not the innovator, of virtual support groups and video chat support groups going all the way back to 2010. And we're very honored to come together with us2, to collaborate with us2 to present this, this very unique topic. Parents rarely talk to their kids about their diseases and their conditions, and they need to. And this could really be a first that in discussing this subject publicly. And later on this year, we're going to go on and have another discussion, another TheTalk discussion for ovarian cancer, and we're also going to do one for MS. So stay tuned and sign up for our reminders on ancan.org, and you will get to participate in some of the others if you have an interest. So it falls upon me to introduce a truly illustrious panel. And first of all, I'd like to turn to the medical professionals. Dr. Ryan Berglund, who is a urologist at Cleveland Clinic, educated at Harvard, Columbia, Memorial Sloan Kettering, and now works at Cleveland Clinic. And Dr. Berglund is a spokesperson for Mention It, which is a men's health awareness campaign. And he is going to talk to us a little bit about that campaign, which will dovetail into the panel. And I will say that it was because of Howard Walensky, a medical journalist who's on our advisory board, and his discussions with Dr. Berglund, that this whole idea came about. So, so I want to give some kudos to both of them and to thank them. In moderating the panel will be Dr. Alicia Morgans, who is one of AnCan's most favorite genitourinary medical oncologists. Dr. Morgans was educated at Penn, Vanderbilt, and Dana-Farber. She practices at Lurie Comprehensive Cancer Center, which is part of Northwestern. And from what she's told us before, she wanted to be a doc from a very young age. There was cancer in the family, and in fact, her grandfather had prostate cancer, and he died sadly just within the past couple of years. Dr. Morgans is a professor at the med school. She's a Prostate Cancer Foundation Young Investigator, and her specific areas of interest lie around quality of life from advanced treatment, and particularly cognitive issues and exercise. But we know that her patients love her because of her manner and her compassion, because they come back and they tell us that. And I think you'll all get to see that. And just in case you don't think she's busy enough, I think Dr. M has a couple of little ones at home as well. I'd like to take the opportunity now to introduce the panel to you. And all of the panel, the dads all have prostate cancer to some degree. And so we'll start with Elliot Kerman and his son, Jules. Elliot was diagnosed with prostate cancer in 2019, pretty recently, with disease demographics that are sometimes challenging for active surveillance, but with multidisciplinary consults at Memorial Sloan Kettering, he decided to follow active surveillance, and he's going to be representing the active surveillance folks who are listening in and who are having conversations with their kids, we hope. Secondly, I'd like to introduce Jim Schreit and his son, Brian. And Jim is, in fact, the board chair at us too. Jim comes from 2 previous generations of prostate cancer. And he himself was diagnosed in 2010. He immediately had surgery when he perhaps could have been an active surveillance candidate. His prostatectomy was successful, but he endured significant side effects, which have very much impacted both him and his family. And he has publicly admitted that if it wasn't for his son, Brian, he might not be with us today. Our next pair is also a board chair, Peter Kafka, who is our AnCan board chair. And Peter was diagnosed symptomatically in 2014 with very high-risk disease. 6 years on, he's done every type of prostate cancer treatment known to man: surgery, radiation, hormone therapy, and he's currently finishing up chemo. And similar to Jim, Peter's father also had metastatic prostate cancer that took him. And on top of all of that, Peter carries an inherited mutation, germline mutation for Lynch syndrome, as well as a somatic BRCA2 mutation. And lastly, we'd like to introduce Carl Foreman to you and his daughter, Sherry Joseph. Carl was diagnosed de novo metastatic in 2018. He immediately started hormone therapy, and he did surgery as part of a clinical trial in New Jersey. He has a very significant family history of cancer, and we pushed him into doing a germline test, and he showed up as carrying BRCA2, an inherited BRCA2 mutation. When his second-line hormone therapy failed in 2019, Carl started a precision drug identified by the BRCA2, a PARP inhibitor, and that's been working well for some time now. And because he was germline positive, both of Carl's daughters tested and both came back positive with the BRCA2 mutation. So that is the panel. The medical professionals, and I'm going to turn it over to Dr. Berglund to tell us a little bit about Mention It. Thank you.
Thanks, Rick. Appreciate the introduction. You guys can hear me okay?
We can.
Mention It, we actually just had our 4th Mention It survey. This was started back in 2016. And we as a group had discovered a couple of things. Number one, as urologists, we were sort of serving as primary care physicians for a lot of our patients because men are not very good patients. This is a broad generalization, but in general don't like to go into the doctor. And so they develop a urologic problem, they'd end up with the urologist, and then we'd be kind of guiding their healthcare for a while. And we realized that that there were some problems with this. Really, we shouldn't be managing patients, we shouldn't be the primary care physician. Second thing is that it's very hard to speak with many men in the clinic, and oftentimes, at least in my clinic, we have to have wives or significant others show up with their partners to get them to tell us the full story. And A lot of it is that we just found out through this survey is that men in general don't like to talk about their health and taking care of themselves, and there are a lot of reasons for that. In each year we've looked at a different angle on why this happens, but the campaign is a campaign designed to raise awareness and encourage men to start paying attention to their health. So let's see, this fourth year of our campaign, the previous year we dug into two areas: men's health motivators and their barriers. Why do they go into the doctor, and why do they not go to the doctor? Men would rather do a lot of other things than go to the doctor. They'd rather do household chores. They are very concerned about being perceived as being weak or troubling or bothering people. And what were the takeaways that we had from our survey this year? So as I mentioned, 72% would rather do household chores like cleaning the bathroom or mowing the lawn. And 20% of men admitted that they aren't honest with their doctors when they go in to be seen. Reasons behind this: they were embarrassed. They didn't want to make changes to their diet and their lifestyle. That was a very common one, about a third of our participants. And many of them were in denial. Many of them knew that they had something going wrong, but they just did not want to have a diagnosis. And we oftentimes see that with our prostate cancer patients. You know, someone who has an elevated PSA that probably needs a further workup, who just simply don't want to know. So the last thing is that many of our patients are very busy, and going into the doctor can be a real hassle. And almost 2/3 of our patients said that if there was a way to get in to see the doctor in a more convenient fashion, they'd be more willing to go in and be seen. So we had a little video to follow this. We can post where the video is, but that's just kind of a summary of what we've been doing with these surveys. You guys are scaring me with your silence.
I think Alicia's muted. Hold on.
Thank you. Sorry.
Sorry. No, I don't know how I got that.
I wasn't allowed to unmute myself.
Okay.
I feel like my family would like that control over me sometimes. So thank you for unmuting me. And thank you for sharing that really interesting information, Brian. I find it, I dislike cleaning bathrooms a whole lot. So if somebody really would rather clean the bathroom than go into the doctor or have these conversations, that's actually saying a lot. And it's something I think that we can all relate to. So for this portion of the meeting, we're thinking about reflecting on what Dr. Berglund has said, and also having a conversation with the panelists that we heard introduced just a few minutes ago. I really think it's important that we have people who are participating with us who are patient and son or daughter pairs, and that we really have people who are spanning the spectrum of prostate cancer as we know it, from active surveillance all the way to advanced disease. And I think that this session will really lend itself to question and answer too from you. So if you can, please feel free to send your questions in while we're talking. And I'll start us off by asking some questions of the panelists. So let's start with someone I already know well. Jim, I would love to hear comments that you might have when you hear what Dr. Berglund has said, and you know your own experiences. What are your thoughts on that? And certainly feel free to call on your son, Brian, who has perfect facial hair, just like you. He's unmuted. Could somebody unmute Jim Schrade?
Yes, I'm sorry. I am so sorry. Hold on.
Okay.
I gotta find him. There he is.
And maybe his son, Brian, also.
Unmute audio. It is not letting me unmute Jim.
So just to remind you while we're unmuting him, Jim is a gentleman who was diagnosed with maybe a lower or intermediate risk prostate cancer, who's undergone a prostatectomy and has had some experiences dealing with the side effects of prostatectomy, but also has had the experiences talking with his son, who's been a major part of his support system. And it looks like they
are unmuted.
Unmuted. Thank you.
You're
Jim,
welcome.
what are your thoughts?
Okay. I think one of the things that I could really relate to is the idea of not wanting to know. I mean, it's just really not only scary, the disease itself, but the treatment options are simply not very pleasant. And I think, you know, there's a concern on my part, at least, that you need to be proactive about this. You do need to go to see the doctor, but you've got to protect yourself, both from the disease and from the potential of unnecessary treatment or treatment that is not well suited for you. And I think, you know, a lot of my issues really revolved around treatment regret and a corresponding clinical depression. And Brian was really instrumental in helping me with that. He was in college at the time at Purdue. My wife and my daughter were at home. And I think when you have somebody around that's depressed and angry all the time, you kind of pull back. So it's almost easier to reach out to somebody who's not there day by day. And you know, he was always there for me. And we would at times spend hours on the phone.
So Brian, as the son in this relationship, and you have clearly been a wonderful, wonderful support to your dad, really have helped him a lot. How did you embrace that role where you talk to him about his health? Because that's really one of the things that we're focusing on today. How do we support each other in these parent and child or adult-child relationships, especially as a college student? You're transitioning from being essentially a child to an adult, and that can be complicated to really broach that relationship. So how did you do that, and what advice do you have for folks on the webinar?
I mean, honestly, if you know, my dad could call me day and night, and I'd be happy to talk with him, no matter what was going on with my life in school and everything. And I mean, the bottom line is really I just did a lot of listening and being supportive and being there for him. And I think that was one of the key factors. I don't think there was any special, you know, things I said or did or anything like that. I think a lot of what I did was listen and, you know, be a sounding board for him, and just being there. And, you know, whenever I would come up, you know, to Chicago from Purdue, we'd go get a burger and a beer and talk. And, you know, those, I really enjoyed that and being there for him. But, you know, the bottom line for me was just being able to listen and let him talk and vent sometimes, you know, because I don't have all the answers. And it was kind of something that just fell into my lap. I didn't, you know, raise my hand and say, hey, Dad, I'm here, I'm your support system or anything. It just, that's what it turned into over time.
I think somebody said unmute Alicia. Brian, I was going to ask you a question. How old are you? Just out of curiosity.
I turned 30 in December.
So you're technically a millennial, correct?
I guess, yeah.
One of the things we found in our survey is that there really is a generational change, and that is that our millennials are much more interested in talking about health with their fathers than prior generations. So we found that the baby boomers, the Gen Xers, were not very interested in talking to their fathers, but over 2/3 of millennials tell us that they wish that they had had a close enough, but it's not a close enough relationship, but that they had felt comfortable enough to discuss their health with their parents. Very relevant to you, because just having had your father have prostate cancer, you're going to need to get screened at an earlier age, and you're going to need to be aware of the potential threat down the road. So it's very important that you and your dad have a close relationship where you can talk about health issues together.
Absolutely.
Yeah.
Sorry, go ahead.
Yeah, I completely agree, and it is an uncomfortable topic to talk about. It wasn't exactly easy for me to grasp some of the things he was going through, but the more we talked and the more I listened, it seemed the better things got, and we have a much stronger relationship now.
So to Dr. Berglund's point, are any of the other pairs Gen X? So a little bit older adult children, and if you are you willing to admit it? And then also, what was your experience like? So I think that Elliot and Jules, if that's Jules there, yeah, he's definitely not Gen X. Definitely not Gen X. So I'm not sure about Peter and Jeff and Carl and Sherry. So Carl, can we unmute Carl and Sherry, please?
I'm here.
Oh, yep, we can hear you, Carl.
Hello.
And Sherry. So this is our father-daughter pair. So can the two of you talk about what your experience was? It may be different than Brian and Jim's, and how you ultimately found the connection that allowed you to talk about your health.
I think for us it's quite different, because it's father-daughter as opposed to father-son. Yes, we both have a BRCA2 genetic mutations, which is what we share, but it's a different story for us than the others on the panel.
So tell us about it.
Well, as those people who are on the call and know me, I'm a big researcher. I've done a lot of things on my own. I've gotten multiple second opinions. I've been to several major cancer centers and had to cull all the information together and decide on who ultimately would be treating me and the course of action. So a perfect example is that early on in my treatment, which is about 2 years now, the oncologist had recommended that I go onto an initial course of docetaxel. And there's a term, ABC, anything but chemo, but I don't think I'm necessarily in that frame of mind. I'm leaving that as an option, maybe down the road, but in my research, I had seen that, well, Zytiga could be just as effective as docetaxel initially. So I talked to the oncologist, he checked it out, he said, okay, let's go on to Zytiga. I was on that for 6 months, and then after I participated in a clinical trial at the Rutgers Cancer Institute, and part of the trial was to determine the effectiveness of having a robotic surgery for a person who has diagnosed myself as having advanced stage 4 prostate cancer, which typically surgery is not necessarily an option. So I had the surgery, went on to have the genetic testing, as Rick mentioned in his group, AnCan. They had recommended that I pursue that, which I did, and that's where I was found to be BRCA2 positive, and then went on to the PARP inhibitors.
So this is, like you said, Carl, this is a different story. This is a story of you investigating, and then you found information that you knew you had to share with your family. And I think one of the reasons I'm so grateful that you are here today is that this very clearly demonstrates the importance of talking with daughters and sons about health, because BRCA2 is actually a mutation that in men increases the risk of prostate cancer. It's the most common heritable defect that we know of that is targetable, at least at this point, in terms of prostate cancer. And in addition to causing prostate cancer, it actually can cause ovarian cancer and breast cancer in women, pancreatic cancers as well, and some other cancers that are less common. So very important as we think about our health and as we think about talking with families, that we aren't just thinking about sons. And I'd love to hear from Sherry how that conversation went and what you felt as you then how you decided to investigate further.
Sure. So my father took the color test to find out about the BRCA2 mutation. So it was a pretty easy test to take to determine whether I had the BRCA2 mutation as well. So did that pretty immediately. I had actually done 23andMe, and looking back at 23andMe, there were new results since I had taken it a long time ago, and the results had filtered in that I was potentially a higher risk for BRCA2, which was interesting because I didn't even think to investigate or look that it had that type of information. And then the color test validated that. So, I mean, it's a bit overwhelming because, you know, my father's going through prostate cancer, which you hear about prostate cancer and you think, oh, that's, early detection. You mentioned we have cancer in the family. So my father has always been extremely diligent about his health. So it was a shock to find out that he went from, something that is early detection, which he, did, but that progressed so rapidly, and that, BRCA2 caused that change, that rapid change. And of course, then it was overwhelming to find out all of the high risks that you mentioned that BRCA2 causes in women. I'm kind of borderline Gen X. I'm 39. So it's, I have 2 young toddlers, and just the thought of going through and that information and the decisions that I would have to make were quite overwhelming. But I got connected with Sloan Kettering. They have great early detection and made it seamless for me to get that monitoring. And I feel like I'm there frequently, but be observant for myself as well as, there for my father while he's going through this as well.
So before we let you off the hook, Sherry, and I so appreciate again that you're here and that you're sharing your story. I imagine at Sloan Kettering you talked to genetic counselors who helped you think about yourself, your dad, and also your kids. So this is not just, parents and their adult children or their semi-adult children. It's actually, it goes all the way down to grandchildren potentially. These are heritable mutations that can go generation to generation. These are not things that skip a generation, just to be clear. They go from one to the other. Either they're inherited or they're not. If they're not inherited, like if Carl had a BRCA2, Sherry had not had a BRCA2, her children would not have a BRCA2. But if she has the BRCA2, as she does, her children could have that too. So what were your conversations like with the genetic counselors, and how do you think then about toddlers can't get breast or prostate cancer, thank goodness, but how do you think about them and what that means?
Yeah, the genetic counselors were helpful in understanding more about the BRCA2 mutation. I think there's a bit from between BRCA1 and BRCA2, a bit of misinformation. I found even visiting my regular gynecologist who, would monitor for ovarian, and that's very hard to track. But they actually had me kind of worried when I first had my visit, because in their mind they were talking to me more from a BRCA1 perspective of I had to make an immediate decision to go get an oophorectomy and make the decision whether I was going to have any more kids or not, which that was very stressful all of a sudden to get that type of information. Then talking to the genetic counselors, and then in turn being connected to the gynecological oncologist at Sloan for getting deeper insights and information. I got knowledge, you know, they say is power, right? So understanding more about BRCA2 and where my risks would increase, and understanding that I had a bit more time to weigh my options and understand and you know, focus if I wanted to grow my family, and take the time to determine when I should have, you know, preventative surgeries and do that. So I think being informed is critical, and understanding what it is and what it isn't, because there's a lot of misinformation out there. So ensuring, you know, going to the experts that are very knowledgeable about the different traits and the nuances is really important.
I completely agree. And just to pick up on some of those pieces of information that Sherry put out there. So she mentioned 23andMe, which is something that people can order from the internet. You can get that pretty easily. Lots of people have had that. What 23andMe is not is a complete genetic profile like you would get with a genetic counselor, or even with color, which you can actually order. That's something that people can order as individuals as well. We usually recommend that people get that kind of genetic testing under the guidance of a physician, just so that they know how to best interpret that information. And actually, like Sherry said, there are updates over time to those genetic tests that there are things called variants of uncertain significance. So mutations in these genes that we are not sure. We know that they're mutated, but we are not sure if they cause cancer in the way that other variants do. And over time, the information about these genes is actually updated, and that information is circulated with genetic counselors and with others who are in this world. And actually, they are circulated often with the people who awarded the test. But if you get the information and you don't know how to use it or what it means, you actually might have no idea what it is, why it's coming to you, and just put it aside. Mm-hmm. So it is helpful, I think, to have these physicians or genetic counselors who are phenomenal to help you, especially with those updates. But 23andMe actually is only testing for a couple different BRCA mutations. It's not testing for the panel of all the things that could be problems, even with BRCA2 or BRCA1. So it's a very limited panel, and it is not sufficient if you are a high-risk family. And so something for everyone to be aware of. So thinking about getting support, because there are updates over time, and trying to use more complete screens can be really, really important, as we have heard. I'd love to hear from Peter and Jeff, who I think are maybe in Hawaii and are not muted, or maybe muted, I can't tell. I don't think you're muted. You are also a family who has a BRCA2 mutation involved in prostate cancer. Would love to hear how you've dealt with this, how you've thought about it, and how you've communicated as a family about that.
Okay, I am unmuted, correct?
Yes.
Okay, yeah. I think Rick failed to introduce Jeffrey. I have two sons, both in their mid-40s. Jeffrey lives here in Hawaii, in Maui. We live on the same property he lives with his family, and including a couple of grandchildren. So Maui is paradise until you get seriously sick. And then the West Coast is paradise. So I have had no qualms about jumping on a plane and traveling 2,500 miles for whatever treatment I needed. I was lucky enough to find a great medical oncologist down at Prostate Oncology Specialist 6 years ago from the get-go. And Dr. Turner's been with me ever since. I just sent an email to him yesterday saying, thank you. I don't think I'd be around if it wasn't for you guiding me. If anything, I find I'm probably too communicative. I have to let my sons know that there's life beyond prostate cancer. That doesn't totally define who I am and what I am, but in the 6 years I've been dealing with this, it's been amazing. The changes in medicine, I mean, things like genetic testing wasn't in the picture originally when I was diagnosed. PSMA scans, all kinds of second-line anti-androgens, things that I'm taking advantage of weren't even in existence. So Jeffrey has known about every step I've taken. He's followed me out to California on several occasions when I did surgery, when I did radiation, various different things. So he knows, and my other son up in Canada knows everything I'm doing. My BRCA mutation is somatic. I got that from Foundation Medicine, but my germline mutation is a Lynch syndrome mutation. And that's an interesting one because I watched a webinar with Dr. Sartor in Louisiana, and very low percentage of men with an MSH6 mutation develop prostate cancer. So I don't know totally what's driving mine, whether that is or not, but you can't miss the forest from the trees. A Lynch syndrome diagnosis means you have a huge proclivity for colorectal cancer, about 50% chance. He had a very small percentage for prostate cancer. So I have to let my son know that. I know when my father was sick, he was a adult onset diabetic, and he was very concerned that he was going to pass that on to me. And lo and behold, it was prostate cancer he passed on to me. Little did I know. So I can't get too involved in the prostate end of things, but I need to make sure that my sons know that there are other indications there and they need to watch it. That it isn't just getting the PSA test. They might need to start very shortly getting regular screening, not just every 10 years for colorectal cancer. So I'll let Jeffrey, as I said, I say too much sometimes.
That was perfect.
Yeah, I know some of you know my father, and yeah, he worked, he had a illustrious career for over 20 years, and that came to an abrupt end when he was diagnosed. And pretty shortly thereafter, he kind of dove headlong into prostate cancer research, just trying to dig up and find out everything there was to know about the disease. And then, and shortly after that, he turned to helping other people who were suffering from that, or, and I quickly realized that he gained an immense knowledge on it, but there are a lot of men who have really no idea, really no clue, and just kind of stumble into the doctor's office and do whatever they say, whether those doctors really know what's really going on or not. So my father really helped a lot of people like that. And I saw that whole situation play out, and my dad he's talked to me before about, genetic testing, tried to, get my brother and I to do the color test, but we haven't yet. And the reason, I can't speak for my brother, but the reason I've chosen not to do it is because I feel like if I somehow have that genetic, if I'm more likely to have it just from hereditary reasons, then I can't really change that. And I'd rather not stress about it and worry about it. And in the meantime, I do my best to, live a healthy lifestyle as much as possible, eat healthy, exercise, and, and I think, that can go a long way as well. But I'm also aware, and I know, and I saw my father, his symptoms, and I saw his own doctor fail to recognize those symptoms for years. you know, and let it like a long time pass by, which did some serious damage there and lost time. So I'm like acutely aware of that. and we'll remember that going forward, you know, and what signs to watch out for.
Well, thank you both. You've actually just given us a bunch of things to talk about and to dig into. We're also getting questions and answers, but before we get into those, I just want to really make sure that we highlight a couple things that this dynamic duo, a father-son duo, has shared with us, because these are all really important points. So first, just to speak initially to what Jeff mentioned, it is your choice. Once you learn the information about your parent, it is your choice whether you want to do something or not. And Sherry made the decision to go forward to talk to genetic counseling to get tested herself, and Jeff did not. And these are things that, you know, ultimately everybody has their own choice to make, but it's important as the man with prostate cancer who's getting the genetic testing. It's really important for you to give your children that choice, I think, because if you don't get tested and you don't share that information with them, or you do get tested and you don't share that information with them, you're not giving them the power to make that decision for themselves. And I think that that's just really, really important. And Jeff is not alone. There are definitely people who choose not to look further. But there are people like Sherry who say, I do want to look further because it's going to affect the way that I'm screened for things like breast cancer, or for people with MSI high, with MSH6 abnormalities, Lynch syndrome, they might get screened differently for colorectal cancer and also things like prostate cancer. But everybody should have that choice, and we should give that, I think, to our children to be able to make that. The second point that I really want to make is that we heard from Peter that he has a BRCA2 somatic mutation. That is different than a germline mutation. A germline mutation is what Carl has. Carl had something that he inherited and something that Sherry has now inherited. But Jeff actually cannot inherit the BRCA2 mutation from Peter because it's only in the tumor. So there are two types of mutations that we have to think about. There's genetic material that's in all of us that we get from our parents and that is actually also present in the tumor. But the tumor can have its own mutations. Those are called somatic mutations. They only occur in the tumor. They don't occur anywhere where they can be passed on, and they are not inherited. So there's the germline stuff that we get from our parents that can be detected by things like color. And there's the somatic stuff. These are mutations that only occur in the tumor. They cannot be passed on. Actually, both of these mutation types can be targeted with new medications that were approved actually just last month. PARP inhibitors, things like rucaparib and olaparib. So we have two choices here in the US at least. Two medications that can target these mutations that you either can have because you inherited them or because they occurred just in the tumor. And that's going to be important as you move through your journey and your conversations with your children, because a somatic mutation is not something that your children can inherit. The final thing that I wanted to really emphasize from Peter, who's clearly a great teacher, is that he inherited an MSH6 mutation, which is actually a Lynch syndrome mutation, which is just a group of mutations commonly referred to as Lynch syndrome. But it can cause something called microsatellite instability. We abbreviate that by saying MSI. MSI high tumors actually have another class of medications, one particular medication that is specifically approved for any tumor, whether it's colon or brain or kidney or bladder or prostate, that is MSI high, pembrolizumab, also called Keytruda. So if you have a tumor that is MSI high because of a mutation like MSH6, which is the most common in prostate cancer, you could potentially get pembrolizumab, or also called Keytruda, an immunotherapy that could help with your prostate cancer if it's in your prostate cancer, or could help with your colon cancer if it's in the colon or wherever else. This medicine has been approved for a few years for anybody with that particular mutation, or with MSI high tumors. So these are all really important things. Tumor-specific mutations are somatic. things we inherit are germline. They can be passed on. And there's different mutations actually. BRCA1, BRCA2, and a series of others that can be targeted with PARP inhibitors, new treatments just approved. And then these MSH, MLH mutations that cause MSI high status, those can be targeted with pembrolizumab, also called Keytruda. So lots of stuff in there. But one thing I wanna go back to Dr. Berglund about. So when you talk to families and you have a gentleman who has a BRCA2 mutation, say, that is germline, and it's now in his son, how do you counsel that individual in terms of guiding his son for prostate cancer screening and follow-up and thinking about things like active surveillance? What are your thoughts on that?
That's a great question. When I was at Memorial Sloan Kettering, Peter Scardino had a very interesting thought experiment that he gave us, and that was, there is one way to eliminate all prostate cancer. You know what that is? Remove everybody's prostate when they're 20. So you can take the argument to a ridiculous extreme, but the treatments that we have now for prostate cancer are not your father's prostate cancer treatments. So if you look 20 years ago, when I graduated medical school, I can't believe it's that long ago. I've got a few gray hairs now, but if you had prostate cancer, if you had a low risk prostate cancer, you got your prostate removed. Maybe got it radiated, but you got your prostate removed. Intermediate risk disease, you got your prostate removed, you got radiated. And high risk disease, you probably got hormonal therapy, androgen deprivation therapy, or an anti-androgen. Now, more than half of my patients I don't treat. More than half my patients are on active surveillance. We're actually getting a lot better at figuring out who can be safely watched. I think we're going to get a lot better than that. And then you can take this thought experiment to the extreme. Are we going to get good enough at predicting outcomes in patients where, like with the BRCA2 female patients that elect to undergo prophylactic surgery, could we potentially think about doing the same thing with the prostate? It's not a far-fetched idea, that you say by a certain age you should have your prostate removed if you have certain genetic predispositions. I would argue probably the most important PSA you get in your entire life, if you're going to check your PSA, is probably in your 40s. An elevated PSA, a PSA above 1.5 in your 40s is actually fairly predictive of somebody who goes on to have problems later in life in prostate cancer. It doesn't necessarily mean that you have prostate cancer at that moment in time. Am I proposing that somebody who has a genetic predisposition should get a prophylactic prostatectomy? Absolutely not at this point. But those patients need to be carefully screened. And by carefully screened, I would argue annually. So starting at age 40. And certainly if you have a first-degree relative that has had prostate cancer before the age of 50, or multiple first-degree relatives, you should be screened at an early age and frequently.
Great. Well, thank you for saying that. There was one other thing that I wanted to mention about MSI status. That's only about 3% of all prostate cancers, but people, they're out there, they exist. We have one here on our panel. And drugs like pembrolizumab can be really, really helpful for them. So 3% of people. And then just to get back to Dr. Berglund's comment, I think that when we're thinking about screening, we're thinking about moving that earlier. Dr. Berglund, what are your thoughts on PSA? What PSA, should that be coupled with the DRE? What are your thoughts on that for the younger folks?
Gosh, I mean, I got to tell you that, there are a lot of misconceptions about it. There are a lot of primary physicians who still recommend against any form of PSA screening or prostate exam based on what I would argue was a flawed U.S. Preventive Services Task Force recommendation against routine PSA screening, giving it a D score, a score of D. It's still the most powerful tool that we have to screen patients. It's very inexpensive. It's very easy to obtain. It's just a blood draw. And I think in the right hands, it's a very powerful tool for diagnosing prostate cancer. Should we be getting PSAs on patients over the age of 80? outside of very, very select circumstances, no. Could we be getting PSAs in patients under the age of 40? In very rare circumstances, but really no. But in between there's a lot of value in the right hands. I think that the biggest argument against PSA screening has been overtreatment. And I think we're getting a lot better at the overtreatment side of things. So it's not, PSA is not the problem, it's what you do with the information afterwards. And there certainly was an era of overtreating patients, and it wasn't a malicious or malignant thing, it was just we didn't understand. You know, prostate cancer was prostate cancer and you were treated regardless. You know, those days are behind us. Most of my patients, it's a rare low-risk patient that I treat. There's some exceptions, there's some reasons that we do it. And even in the intermediate risk group, which you know, for a long time we thought would always require treatment, there's some patients that are good candidates for that. I would argue that in a patient that has a less than 10-year life expectancy, whatever the reason may be, whether they're in poor health or age, there's probably not a lot of value to PSA screening. And it's a difficult conversation to have with people, you know, talking about how much longer they expect to live.
Yeah, but still important, I think, that we give our children the choice to go in and have that conversation about PSA screening by talking about our health and making sure that they know about that. And before we get on to Elliot and Jules, who we are getting to, because that's our pair who really can speak to active surveillance and how they talked with it. I don't even know if you're old enough to be in a millennial, Jules, but we'll get to you in just a second. I didn't think so. He's shaking his head. I wanted to mention to Dr. Berglund and ask his opinion. So we're talking about heritable things that we can measure and identify. There are definitely things that we have not identified yet. And I could think specifically of African-American men and their children are at higher risk of developing prostate cancer, and they are still at higher risk of dying from prostate cancer than Caucasian men. And we are all making efforts every day to try to stop this, but we have not identified a genetic reason for this yet. And of course we're studying it, but what do you recommend in terms of families, African-American families, where the father, maybe grandfather, uncle, somebody has had prostate cancer, and how do you recommend that they think about and talk to their sons about that when there isn't an identifiable thing that they can say, we have a BRCA2 mutation?
Well, you know, a question that I get asked from patients all the time. I'm 47, full disclosure. And the question was, have you gotten your own PSA checked and have you had a DRA? And you know what my answer is? I did. I got my internist offered it when I was age 40. I had it checked. I had it checked again this year. So I think there's certainly in a population that has a predisposition to the disease, I think that early screening has value. I know that's controversial, but I would argue that an African-American male in their 40s should get their PSA checked at least once, maybe twice. And one of the arguments is that, you know, if your PSA is less than 1, check again in 5 years or check again when you're 50. But it's these borderline PSA levels that are so critical. The Swedish data shows that is probably the most important PSA you get in your life is a slightly elevated PSA in your 40s. So I would argue in those populations, very reasonable to start getting checked in your 40s.
Well, thank you for saying that. And I'd like to circle back on this topic after we talk to Elliot and Jules. And I'm wondering if we can, I don't know if he's able or willing, but when we do circle back, if we could talk to Bo about his thoughts, I would love to hear them if he is willing. But let's move quickly now to our last official panel members, Elliot and Jules. And Elliot, do you know what generation you're in? If you're too young to be a millennial, what's the next generation?
I think I'm Gen Z.
Oh dear, okay. They just keep piling up. All right, well, very good, nice to see you. So Elliot, can you tell us a little bit about your story?
Yeah, my first PSA test, I was 60, and I was one of those people who just kept turning down the opportunity to get tested, and I finally said, sure, why not at 60, and it came back at 5.8. So I went, I started dealing with, I went to Sloan Kettering and had everything, 4K score test, then an MRI, a biopsy, and then eventually the Polaris test, which helped me decide to do active surveillance, even though I'm intermediate 3+4. So, you know, it's borderline, but I'm in the zone for active surveillance, and I'd much rather do active surveillance than treat. And since then, so that was 9 months ago I was diagnosed. So I'm learning so much from this as I do from pretty much everything I do now. I'm just literally soaking in information at this point. I took my time. That was one thing I did learn early was I didn't have to make any decisions quickly. I ended up getting 3 different opinions. And 2 of them were from Sloan Kettering, and one of them was from somebody who I knew peripherally, which I think was a great thing because there was, I felt like that person had no skin in the game and had nothing to gain or lose by anything that they said to me. And that was really valuable. And then once I decided on, you know, I did tell the boys, I have an older son too, who's 21. I waited till he came back from college. I told them that I had it together. And that was a couple of weeks after I was diagnosed. And I still didn't know what I was actually going to do about it. And I didn't decide for about 2 months about how I was going to do active surveillance. But once I made that decision, I dove in head first, and I do what I've read on the ASPI website is empowered surveillance. So I changed my diet completely. I take a lot of supplements, I exercise, and I sleep. I try to get at least 7 hours of sleep every night if I can. So I'm gung-ho, I'm, you know, all in, and my last PSA test was down to 4.35, so I'm happy about that.
Okay, great. Well, before we get to Jules, I just want to emphasize active surveillance is an active process. It's not what we used to call watchful waiting. We still call it watchful waiting, which is essentially you don't do anything until there's a problem and then you intervene, which we sometimes do in situations when people have a lot of other medical illnesses, they're very elderly, and they intervening on their prostate cancer is actually not their biggest problem. They may have other bigger problems. But active surveillance is engaging, it's going to doctor's visits, it's getting your PSA checked, and it sounds like you are doing even more than that. So great work. Jules, I'd love to hear from you about how that conversation went. How did your dad approach you? How much did you draw a line and say, Dad, I don't want to know anymore at some point? Or did you just say, you know, tell me everything, Dad? So go ahead.
Yeah. You know, I'm a pretty open person. You know, we've always had like a pretty much an open environment in the household. So, you know, obviously it was really overwhelming at first when he told me, and it was pretty hard to get my head around. But, you know, we started talking about it more, and, you know, I started learning about it just more and more here and there. You know, I still don't know like that much. I'm not nearly as much as him. He like researches constantly, but you know, I do remember having a few conversations specifically about like the decision about whether he was going to treat himself or he was going to do active surveillance. And, you know, I wasn't really opposed to learning anything. You know, I didn't really draw the line. You know, I was simply I just wanted to know, because I care about him a lot, and I think it was super important for me at least to understand like the full scope of what's going on.
So at 19, you're not going to use that information today, and I'm not sure that you thought about this, but do you think you're going to use that information in the future to affect your screening decisions? Whatever you say now does not hold you to anything. I think a lot of people are just curious, you know, did you find that information helpful? Of course you're supporting your dad, but was that helpful as you think about yourself?
Yeah, certainly it was. You know, we didn't really talk about the genetic component to it. he told me that it is possible to go down the line. But until he told me, until he asked me to do this session, in fact, I didn't really know that it was possible. So, I haven't really put much thought to it, but I definitely would consider approaching, just based on the fact that he does have prostate cancer,
Yeah.
Yeah, I'm not sure what else to say. It's pretty difficult at this point to determine.
Well, you should not have to think about prostate cancer in yourself right now at all, Elliot, or not Elliot, I'm sorry, Jules. And also, it's important when we talk about germline testing for prostate cancer, the recommendations and guidance right now, and remember, this is what you can inherit, what you can pass on. It's actually for patients or for men who have high risk localized prostate cancer, all the way up through recurrent prostate cancer, metastatic prostate cancer. So intermediate prostate cancer, especially a 3+4, is probably not, at this point at least, recommended for genetic testing, for germline testing. The reason for that is that the higher the probability that you have a mutation, the more valuable a test is going to be, because the more true positives it's going to have and the less false positives. And if you have a population with a high chance of having a mutation, and the more advanced the prostate cancer, metastatic disease in particular, castration-resistant metastatic disease, the more advanced that prostate cancer, the higher the chance that you have inherited a mutation that you could then pass on. Localized prostate cancer has a lower rate of these driver mutations. And so there's just this spectrum. For you, Jules, your screening recommendation is not necessarily going to be based on something that you can measure in a blood test that you inherited from your dad, but because your dad had prostate cancer, you do have a slightly higher risk. Dr. Berglund, what would you say to somebody like Jules in terms of when he should start thinking about things like PSA screenings?
I think the recommendations for him are going to be a lot different than they are right now. So it's not an issue for him right now, but I would argue that something is going to happen at age 40. Now, that's 21 years from now. And just reminding you that things were very different 20 years ago. It's not far-fetched to think, could there be, a perfectly reliable set of genetic markers that we could use, or could we have some breakthrough treatment or some way to approach this that's completely different than now? So I think it's hard to talk to a 19-year-old about this because we just don't know how things are going to be. The way things are right now, I would start screening early and frequently with his family history, having a first-degree relative. But it's going to be a lot different in 21 years than it is now.
So that's a really important point, that, as time goes on, we talk a lot about PSA right now. We talk about digital rectal exams. We talk about the problems with the PSA test. And we also have heard people mention other tests like 4K, PHI, lots of different tests. We are continuing to improve and evolve. And so in 20 years, when it's time for you to think about testing, the testing may be different. And actually, maybe the testing will be, like we heard, a perfectly reliable blood test that you can have at age 35. Who knows? But I think that progress is always something that we hope for, aspire to, and we're making it. So just be on the lookout and be aware. But we've also heard, don't let it monopolize your life. You're 19, live and do what a 19-year-old does. And so now we can go back to Bo if he's willing, because I think that we've talked again a lot about these heritable things. We can't always put a finger. Is someone talking? Sorry. Oh, we can't always put a finger on.
Yeah, that was.
Yeah, Brian? Was somebody talking?
Yeah. Yeah, could I make a quick comment? I was Jules's age when, I was 20, and that was 10 years ago. And the conversation we had was, I have prostate cancer, I'm going to have a surgery. And that was pretty much it. There wasn't research or things like that went into it. And, for them to have the opportunity to take that time and research, the outcome has the potential to be so much better. And it's something I really wish, looking back, that we had that option and explored that more. And I think based on what I've seen in the past 10 years, things have come a long way. And as they continue to advance, I think in the early stages, definitely having conversations, doing your research, talking to different people can really prevent, outcomes that, my dad experienced. And, I think, he's very fortunate to have that option. So, have that conversation from the start and don't just jump to one thing right away.
Thank you for saying that, Brian. I think that's really important to recognize that as things evolve and as we have more access to information, we can make choices that are right for us based on the information that we now have available. When information is less available, we still make choices that we hope are right for us. We just are not as informed about the pros and cons sometimes, but the field has evolved. And we've also evolved in our focus at really trying to encourage active surveillance. As we've heard from Dr. Berglund, that has really changed and it has transformed, I think, the prostate cancer survivor experience in many ways. So remember that doing screening, when Brian does screening, when others do screening, if active surveillance is an option, then it may actually be a great option for you that does not involve, I got a PSA, automatically I get surgery, because that's what it used to be, and it is really changing. So just to, yes, Elliot.
Yeah, so the other thing I was going to say is it's actually even more in some ways, like the fact that I've changed my diet and done a lot of the things that I've done for active surveillance is actually, I lost a lot of weight. I feel I'm like $1 million. I actually feel great. So it's kind of weird, but it hasn't impacted me horribly. And like the idea of having to change my diet, it's hard. It's hard on all of us in a way because I have to eat differently and all of that. But I do feel great, so.
So that's fantastic, Elliot, because the rest of us, or at least I feel like I've packed on some pounds in the COVID pandemic isolation that has changed all of our lives. So I'm glad you're losing weight, and hopefully the rest of us can get some exercise at some point soon as well. So Bo, I wanted to just hear your thoughts. We talked a lot about things you could inherit, that you can measure, that you can identify. We can't always identify it. And that's the case for many men with African-American men who actually have lower rates of these detectable BRCA1, BRCA2 mutations. The crime is that we actually don't even know because we don't sequence enough men's genomes. We don't do enough DNA testing of African-American men to really know what the rates of these things are in them, and to really even characterize all the things that we could potentially one day say, this is the reason you have the prostate cancer. We can check that in your son. So what are your thoughts on this, Bo?
Well, this is a tremendous session, even more than I'd hoped for. And I'm a very lucky person. I'm an 11-year survivor. And part of the luck for me was that I was in a system that had me going through screening early and often. And I was not a perfect patient. My first high PSA by my internist, I said, oh, I don't want to hear this. It took me a year before I got my second, but it was elevated. So we started really in the sequence at that point, moved on to biopsies. By the time we actually found my prostate cancer, it was still microscopic. So that gave me the best range of options. If I got to say anything to take away, early detection saves lives. Sharing information is critical. They say knowledge is power. Knowledge shared is knowledge squared. I went through checking with medical oncologists, looked at radiation, looked at chemo, looked at all the options within my own system, Harvard Vanguard, and everybody told me surgery. There was no question. I was 52 years old. They said that was the best suggestion. If I were 52 years old today, they might say active surveillance. Maybe they wouldn't. It doesn't matter. When I was 52, the option was surgery. We chose not to, I have 2 daughters, so no sons, but we'll get to that in a second. But when we knew it was surgery, we told them it was surgery. Still not enough notice, I think, for the kids. They would have rather known what was going on earlier. But my wife and I decided we weren't telling them what was happening until we decided what we were going to do about it. Surgery was very successful. No sign of cancer since. And I do get my PSA and my DRE every year anyway. If it does come back, I want to know soon. What I've learned, I've been a survivor for 11 years, but I've only been in this role since January. I found out about things like BRCA2 having an influence on potentially my daughters as well as on me, and we don't really know yet. Another complicating factor is that my sister Barbie was diagnosed with breast cancer at 28 and died of that breast cancer at 34. So there's already a higher risk there, which everybody in my family knows about. Now, my wife didn't even get to meet Barbie, much less my kids, but everybody knows that story. So they're aware. I have a daughter who just turned 29, another who's about to turn 26. They know the issues. And if I do choose to get BRCA testing, as you say, it's not clear cut, they will know what I know as soon as possible. And I think that sharing among families is critical. I think one of the things that we touched on briefly is this issue of stigma and concern about treatment, making people not get tested. You want to know what's going on and make your choices, if at all possible. I would say that to every man. People sometimes say, well, I don't want to have any. You can take my blood test. I literally had a young black man tell me this, 40 years old. He's young to me now. And he said, you can take my blood test. You can do a PSA, but nobody's sticking their finger up my ass. And I'm like, dude, you're going to put your life at risk for a few seconds? You're going to put your life at risk because what if it feels good? You think that might mean that you're gay? Well, so what? We're talking about your life. We're not even talking about a few minutes in a mammogram getting squeezed. We're talking about a few seconds. You've got to do those tests and you've got to find out what your best options are. I'm thrilled to hear the people doing the research here because, in the 11 years since I was treated, things have changed a lot and people need to know that. And they also need to know that they need to be active no matter how good their physician is. You have to be an empowered patient because you're the only one who can make your own decisions. And it's the same thing you're giving to your kids. It's like, here's the information I've got to share with you. I'm not going to tell you what to do. If you're a young adult, if you're certainly a middle-aged adult, I'm not going to tell you what to do, but I'm going to tell you what I know and share everything that I've got so that you can make the best decision for you. That's what we should want for every patient.
Well, thank you. And I completely agree. And I'm sorry to hear about your sister. And I bet many people on this panel have stories of loss too, because that is life in our country, in our times with cancer. And so this is such an important conversation to have so that we can prevent someone from that experience. And part of that is learning, as you've said, the trials and the things that we do to advance knowledge so that we make progress over a decade. Peter, I think you mentioned that you'd been involved in trials. I may have heard wrong. Maybe you just have had really great care. If you have not been involved in trials, can you just say no, and I will ask if anyone else on the panel has been involved?
Well, I've done 2 PSMA tests, both the gallium-68 and a PYL, both on trial, one at UCSF and one at Stanford. And they've, to speak to Bo's early detection comments, they were both instrumental in, for me, it's not early detection in terms of diagnosis, but it's early detection in terms of spread. And I've been able to treat in both instances, once with proton for metastatic lymph nodes, and more recently for peritoneal spread from a PYL scan, which I'm doing chemo now. And one more quick thing. I had a buddy, a close friend, pass away a couple months ago who was germline BRCA. And I was his advocate. I'd go to all his oncology appointments and so forth. And he did chemo, but I'd lean on the doctor and say, doctor, what about carboplatin? as well as docetaxel. And they'd say, oh, no, I don't have much experience with that. He didn't do carboplatin. He just did docetaxel, and he passed away. And for me, I'm going into my sixth treatment this Thursday, day after tomorrow. I chose to do it at home rather than do it on the mainland. And I interviewed 3 oncologists here, so that I had somebody on the ground running the show. And I only got 1 out of those 3 who said that they'd follow the direction of my oncologist in California and they'd do carboplatin. The other ones refused to do it. They didn't agree. And so you've got to educate yourself. You've got to lean on some doctors sometimes and make sure you're getting the best care, because as Bo said, and others said, this is your life. And if you're going to keep going on and get the best treatment possible, you've got to lean. So that's my final word.
So I would say leaning is really important. It's also important to lean in a way that sometimes you can lean by getting involved in those clinical trials, because carboplatin is something that we actually don't, we have moderate data for. I am glad that you are advising that they consider that for your friend. I'm glad that you're able to think about that for you, because we are trying to do that. And there are actually clinical trials looking at carboplatin right now, which is why many of us are using that outside of the trial just to try for people who are fit, healthy, and well. It is always the doctor's decision to decide, yes, I feel comfortable kind of going a little off kilter, or no, I don't. But you can decide if that doctor is the right one for you or not. And maybe the doctor who says, hey, I don't feel comfortable because you have this other medical condition and I just don't feel like that's going to be safe for you. Maybe that's a great doctor for you, and maybe that's the right choice. But maybe you want to talk to somebody else too, because you have to choose who's that doctor that I trust and that I have that connection with. So it's okay to get a second opinion. It's great to think about clinical trials. We do not learn anything without clinical trials. So definitely think about that. If somebody could unmute Mr. Kumar, he is raising his hand.
Yes, I'm unmuted now, I think.
Yes, go ahead.
Yeah, I am undergoing a clinical trial called PACE. It is an international randomized study to compare laparoscopic prostatectomy versus what is called SBRT, steatobody radiotherapy. Actually, I was diagnosed with prostate cancer about 6 years back. It was that time I was in my early 70s, 71 years, and the first decision was to be under active surveillance for an year or so, which gave me time to look at the different options available. Incidentally, my daughter is a medical doctor practicing in Toronto, so I was with her at that time, and we went through so many options. The first and the most recommended was to go for a surgery, which, considering my age, I was not in favor of. Basically because I was more interested in the quality of life after whatever treatment I take, rather than the longevity or other considerations. So from the beginning, I was very clear that I will not go for a surgery. Then after about 1 year of waiting, the tests were done again, and the oncologist recommended that it's time to do something definite. You can't just wait. So again, the options were either a surgery or a radiation, different kinds of radiation. And the 1 year I had enough of time to do a lot of research. Then I found out that my doctor is I'm very thankful to him, and he's Dr. Loblow in Sunnybrook Hospital in Toronto. And he told me there is a clinical trial going on, where if you sign it up, it is not sure that you will get an option to do the trial they are doing, because it's a randomized. They will take it's something like a lottery, and half the people will be doing the normal treatment and other half will do the new treatment, and the results are compared. So there is a 50% chance that you will get into the new treatment. So I decided to take that option, and after doing the initial trials, and the basic idea was they do a CT scan and then diagnose, and they put markers around your prostate where the treatment has to be done. They put golden beads, the size of a rice, one rice, small one, around the place, and they do this radiation with the help of a computer analysis. The idea is,
I'm sorry,
the idea is, yeah.
Oh, I was just going to say, I think in the interest of time, we only have about a minute left, so I just wanted to.
This is called a PAC. PAC is the name of this clinical trial, and they do this embedment of this thing, and instead of normal treatment of 25 radiation sittings, this is done in 5 sittings with a higher dose of radiation. And it is 4 years now after this thing. I am practically perfectly all right, in the sense I have no continence or any of those problems associated with. Every 6 months, I have to fill up a form, what is the condition, and the trial is going on the 5th year now. I just thought this is relevant information for all.
That is wonderful. And actually, I think the PACE protocol, which is a Canadian study, as you mentioned, by Dr. Loblau, or he was your treating doctor, I believe that is about to be published. I know they're circulating a manuscript for one of the first publications, so I'm very glad for that. And I appreciate you giving your experience as someone getting involved in clinical trials. Just a final thought before I pass everything back to Rick. We all need to think more about clinical trials to support each other on that in our support groups, in our conversations with others. I know Jim's very involved with our research at Northwestern. Bo is giving an encouraging sign, but we also need to encourage a diverse group of people to participate in these clinical trials, because we can't look for treatments for just one population, and we don't know how medications can help a broad array of people unless we encourage them to get involved in clinical trials. And this is going to take connections and collaborations with support groups. It's going to take outreach to your friends to say, look, I did it. I know that there is history that we need to overcome, but it's going to be worth it, because you may benefit, your children will benefit, and we definitely need to continue to strengthen those bonds and to help all kinds of people, every race, everybody get involved in these trials, so we know how to best take care of everybody. So I will pass back over to Rick, because he has to conclude.
I do, and I'm sad to conclude, because I'd like to hear more questions and I'd like to listen longer, and this has just been enthralling, and I feel like we need to probably have another session at some time, because there are just so many family issues that come up that we've had to move through too quickly. And but one thing I really want to thank both the doctors, both Dr. M and Dr. Berglund, for interspersing their own knowledge seamlessly into this conversation, and giving us pointers that are really important. And I suspect that not as many people were able to get on as wanted, but it is being recorded, and we will be sending out that link, and we can all listen again. I want to apologize to Jeff for not introducing you. I am so sorry, Jeff. It was totally my error. And I want to congratulate Jules on getting an extra couple of years in this conversation, because I actually think you're only 17 and not 19. if that's true. So how does it feel to be 19, Jules?
It's flattering. It's flattering for 19.
But thank you, everybody. Thank you especially to the panel that we've recruited. You guys were just, everybody was just awesome. Everyone. And I hope this has been a very helpful and useful webinar for all. And from us two and from AnCan, we'll say good night and thank you.